Welcome to this episode of Women Out Loud. Today we're shaking things up on the podcast and changing the dynamics a little, learning a little bit more about the Surf Coast Women's Health Group. My name is Lara, I'll be your interviewer today, and I just wanted to welcome Niamh, Amy and Court to the couch.
Thanks, Lara.
Hi.
Hi.
Today we'll be talking about endometriosis with obstetrician, gynaecologist and fertility specialist, Dr Edwina Coghlan, who will be joining us in a bit. So getting straight into it, Niamh, what is one thing people get it wrong about endometriosis?
I think one thing that I've found over the years is that there seems to be an assumption that if a person is thinking they have endometriosis, that they have to have an operation to diagnose it, or they have to have an operation first in order to be able to get some help and get some treatment. And yeah, that's definitely not the case.
Yeah.
Definitely not the case.
100%. And Amy, what is endo?
So I would explain endometriosis to a patient in layman's terms that the tissue similar to the lining of the uterus, that tissue can then be found elsewhere in the body, particularly in the pelvis, but sometimes in other locations as well. And it's a chronic condition. So it's something that's the management, it's a long-term thing and it needs management like we do for other chronic conditions.
Yeah, and it's obviously incredibly painful. How common is it?
We think about 1 in 10 women have endometriosis, which is, huge, 10% of female population. That's a lot.
Yeah.
Very much underdiagnosed historically and has resulted in quite a bit of suffering because it's so common and yet underdiagnosed.
I think it's 1 in 10 now, and there's probably still so much more to be done in terms of diagnosis, like the research as well. And, the screening for it could actually be higher than that.
Yeah, and we're seeing an awful lot of new diagnoses now, but that's not because the incidence is rising, is that we're just getting better at diagnosing it.
Yeah. I have so many women in my life that have endo and are always talking about the pain. Court, what is it that actually causes the pain?
Great question. The pain itself is complex. So yeah, in endo as well, it's complex and has lots of layers and multifactorial components to it. So it's different for every person. The pain's caused from the inflammation itself. But over time, different aspects, I guess, can be involved, from muscles, nerves, the actual uterus, like period pain, stuff like that.
Yeah.
So it can just be the spiraling, cascading, big thing pain. Pain's, it's huge. Complex.
Yeah.
For sure. And what's one thing you wish every young woman knew about endo?
I think to not accept suffering, to not accept suffering as part of the sort of female condition.
Yeah.
And if you've got horrible periods and they're very debilitating and ruining your life and your quality of life, it doesn't really matter what the label is, because sometimes the label can be elusive. But to seek help for that. So even if you don't know it's endo, if you've got debilitating period pain, to seek help for that.
Yeah.
But if you have a diagnosis of endometriosis and you're still not being helped, or you're still in a lot of pain, to look for more help or different help.
100%.
Yeah.
And I feel like growing up as a woman too, as a young girl, everyone's always told is, oh, you got period pain or you got period cramps, and it's so normalized. But at what point is it further than that? When are you like, this is actually not just period pain or period cramps? Like, when is it worse?
Absolutely. And I think, as a society, we have a very high tolerance for women suffering.
Yeah.
And historically, it used to be seen as a bit of a badge of honor, and we were told all the time, oh, it's just periods, But it's to sort of begin to reject that, especially for younger generations of women, to reject that label and say, if this is too much for me, and there's objective markers, if you're missing time off school, if you're missing time off work, if you cannot participate in your sport and activities, when you've got your period, to seek help.
Yeah.
Because it is there, but we're beginning to change the narrative about when it's, why do we accept so much women's suffering?
100%. And it goes from like, it felt all while I was growing up as, oh, my period hurts. It's an excuse, but it's feeling more like, acknowledged by other people now that it's actually is really bad. Yeah. And that people are finally actually going, oh, she has bad period pains. Let's take this seriously and actually help.
Yeah, and absolutely, because, uncontrolled endometriosis or untreated endometriosis isn't what we're hoping for.
Yeah.
It is a condition which can't be cured, but it can certainly be treated.
Yeah.
And when we're talking to Edwina about impacts on fertility, it's very, very important that it is treated.
Yeah.
So, not to accept it without treatment.
I just want to welcome Dr. Edwina to the couch. Thank you so much for joining us.
Yeah.
We're getting some more expert opinions. I just want to know, what is like a red flag that just signals to you someone has endo?
There wouldn't be any individual, well, there's a cluster of red flags, I'd say, that you've always got to put it into individualize the story. So the most important thing is you listen to any woman or anyone that's been assigned female at birth story around their menstrual cycle and actually understand when it started, when their symptoms started, what they've responded to and what they haven't responded to. And that's when I start to look at red flags for endo. So ideally, anyone that has painful periods, and that would be no treatment, they're taking time off school, work, going to, they miss their gym class once a month. That's can be 25% of their life is impacted on their periods.
Yeah.
That's a red flag. So if your periods are impacting on your life, school, work, that in itself is a red flag. So you kind of got to map out their periods and how they are, and then what treatment they've had. So have they been put on anti-inflammatories and had adequate pain relief and strategies around the time of their menstrual cycle and what benefit that's had.
Yeah.
And then if they've had any, then we kind of think about the first line strategies of being backed and then any hormonal suppression.
Yeah.
And I might unpack hormones a bit later because
Yeah.
sometimes they're not liked or people are not keen to try them, but they've got a very important role with the menstrual cycle because it's really hard to control the menstrual cycle. It's complex. It's a very complex part of our body, lots of hormones and the way our brain communicates to our ovaries and our uterus. And the way that we control that is with hormones.
Yeah.
And if we can mitigate symptoms and periods improve,
Yeah.
that's a really important thing for women to help their quality of life, but also helps us work out where the pain's coming from.
Yeah. I find from a young age, the moment I got my period, I was like, oh, it hurts. And then everyone's like, you're on the pill now. So is that something that you find a lot of women are coming in, especially young girls, are being like, oh, well, I've been on the period since the moment I've been on the pill. Sorry, it's the moment I got my period. Is that something that is influencing their pain or affecting it or making it better or worse?
Yeah, I'll come back to it just a second, but I just wanted to finish just on the red flag part.
Yeah.
If people aren't responding to that first line treatment and basic menstrual cycle suppression with the pill, that to me is a red flag.
Okay. Yeah.
So lots of good GPs that are good with women's health.
Yeah.
And that should be a skill. When I teach medical students, I would like every single GP to have that core skill that they can do basic first line treatment for someone's periods. And then if it's not responding, then that needs more investigation.
Yeah.
And you should be able to do that without a ultrasound necessarily, other things. Just treat dysmenorrhea. And if it responds, that's great. Doesn't mean you don't think about endo later on, but you've got the symptoms under control. Now, true red flags I would think about red flags to me would be not responding to first line treatment, dyspareunia, so pain with sex, and then any pain with bowels, which we call dysgeusia, or the dys is like dysuria, dysmenorrhea, so pain, and that's often related to those deposits of endo that are around the uterus and cervix, and they are traditionally hit with intercourse.
Oh, okay. Yeah.
And then what you get is, I describe also then this, and then the reason why you want to intervene around that or think about endo is that you then start to go into this chronic pelvic pain or persistent pelvic pain, because I say to my patients, if you come and see Dr. Edwina and you sit down and there's a pin on the chair, you might be like, oh, and you'll jump. But every time you come in and you're like, every time I see her, there's something sharp on the chair and I jump off.
Yeah.
Eventually you'll come in, you'll stop sitting on the chair when you see me because you'll be like, there's a pin on the chair and I know there's one there.
Yeah.
And so your pelvic floor switch is on.
Yeah.
And you get this pelvic floor pain, and then you start to get cross-sensitization with the bowel and the bladder. And so then you go into this realm of persistent pelvic pain because they're all trying to control and protect you. And so the red flags are in there, but it's important to then think, well, this is possibly, and it's not always endo, but if you then treat the endo component, then you kind of hopefully settle down persistent pelvic pain and the implications on that.
Yeah, the pin on the chair is an incredible way to
Well,
explain it.
Or thinking when you touch the stove and you don't know it's hot,
Yeah,
your body does that.
yeah.
Out of your control.
Reflex. Yeah.
And you do it again, and eventually your body will learn, oh, the stove's on. But the first few times, it's out of your control. And so that's the dyspareunia. And then you have anticipatory, going to have sex. I say it's the same as when you're going out for dinner and you know that person at dinner is a little bit annoying in your friendship group. Your like shackles are up.
Yeah, 100%.
So it's your body protecting you.
Yeah.
And the pelvic floor of regulation, that pain, that can stay throughout the cycle. So even though the period pain, the really intense period pain might be caused by endometriosis, that pelvic floor protection, or, it's a dysfunctional mechanism, but that can stay throughout the cycle.
Okay.
So that comes because of the endodeposits, but it's not the endometriosis itself that's causing the pain throughout the cycle.
Yeah.
But that's why we were saying earlier, it's really, really important to treat this, because you can't think your way out of pelvic pain.
Yeah. Okay.
If the pelvic floor is switched on and it's in pain, that's where we have a physiotherapist involved.
Yeah.
But that's why it's really, really important to have treatment. So yeah, it's not kind of useful for your body to accept that pain.
Yeah.
And the other analogy is that, like, we'll frequently get physio involved very early on, because we know 80% of people have a myofascial component.
Yeah.
And so if you do everything else and don't treat that myofascial component, your pain doesn't get better. So that's
what does that mean?
Myofascial is a muscular component.
Okay.
So think about a knot in your shoulder.
Yeah.
And you just, like, it's there because you've surfed too much, or you've got a posture. You get a pain from the muscles, and you've got to treat that. But also, if you don't fix how you're sitting or get rid of those, if they have got endo or nodules up there, you've got to come at them all together. So it takes a bit of time, but the red flags are very much not responded. I don't like the word failed. Have not responded to primary, strategies, and it's still there, and particularly pain, sex with pain, and then missing time off school. What would you say, Niamh? When do you think as a GP, right, this is something that's a bit more than just
missing time off school, definitely missing time off work, consistently, this is every month, and then not participating in sport, just in bed, mental
Do you
health.
find that this is something that's like commonly ignored as like a symptom for women, or what is something that you'd say like?
Yeah.
Not by Niamh.
Oh no. Well, I think I have spoken to women who I've asked in the past, are you missing time off work? And they'd be like, oh yeah, every month.
Yeah.
As if it's nothing.
Yeah.
Or, teenagers, do you miss time off school? Not so much nowadays, but certainly years ago. Oh yeah, just every month I'd be in bed. This sort of thing of vomiting with pain.
Yeah.
Doubled over with, especially vomiting with pain. That to me is like
Next level.
Yeah. I mean, not to pathologize too much, but it's not okay to be vomiting with pain.
Yeah.
Even if that person does not have endometriosis.
Yeah.
That needs to be helped. So yeah, absolutely. And also, yes, if we use a start off of treatment of some description, particularly hormonal control, and that doesn't work, she comes back and says, no, and then that to me is like, right, there's something here that we need to explore a bit more.
100%. And Court, as a physio, I would love to know, like, once you find out like a client has endometriosis, is there a way that you change your practice around that?
Not necessarily. For me, no, not necessarily.
Yeah.
I still do lots of education and explaining what's going on, and how physio helps, and in conjunction with all the other things that are going on.
Yeah.
So from the medication stuff, or sometimes having a psych, or just that multi-disc team that's so important for that person to listen. That's a big part too.
So with the physio, I would say there's been a big shift in how we look at. People have quite hung up on the diagnosis behind their pelvic pain, and I know we're talking about endo, and it's really important, and it's something that forms a huge part of my practice. Periods could be painful without endo.
Yeah.
And you can also have endometriosis and not have painful periods.
Yeah.
So it's all about what the symptom profile is and what the appropriate treatment is to try and really support this young person or woman, or going through fertility, to get their quality of life under control. So that's often when you think about a physio, they often go there as part of that primary treatment because you want to, that also is a way that they might be starting to have pelvic pain.
Yeah.
I 100% don't wait to confirm they've got endometriosis before they go to the physio. That's often happening. The surgical, the treatments that I do for endometriosis, like, minimally invasive surgery, often that won't actually be effective, and we know this until you've done the other stuff.
Correct.
So it's a tool, and it's a really big shift, and it's a good shift. Surgery is excellent for endometriosis, but you shouldn't be having surgery, every year or every few months. It's timed a couple of times, and the intention of the surgery is either, I would say, two groups for me. The first one is quite significant endometriosis pain, and my surgery is a tool, like Courtney or Niamh or a pain psychologist or sorting the IBS out to help with their endo pain from their periods often, and get rid of some of those big nodules and those big, because Courtney's physio is not going to be effective if there's a big nodule behind the cervix. So that's that role. And then at that point, we try to keep things really quiet and then suppress the periods to keep the endometriosis quiet. The other time I do it is someone that actually might not have pain that comes in with fertility, and it's the first time we understand they've got it.
Do you ever find that people are coming in, like specifically with a lot of pain, potentially having endo, and once they get diagnosed with it or without it, they kind of feel let down? Or is it feeling more of like a relief, like, oh, this is what it is now, thank God? Or so it's not endo, so what is it?
Yes. But I think any practitioner that's working in the pain space should be looking at holistically and finding symptom control and improvement of the pain, and trying to work out excluding things, but not, I'm not, as a gynecologist, it's not endo, off you go, because we are a core part of that team. So ideally you're timing surgery, and our imaging is so good now, and that history is so good. So if we've stepped through, they've actually they've tried, and there's this new living guideline for endometriosis through RANSCOG, which has just come out, which is excellent. And that essentially says someone comes in with painful periods or pelvic pain, you stepwise through management with the primary care provider. At the same time you're referring to physio, you're thinking about a pain psychologist, you're thinking about all the holistic approaches to pain, like you would for back pain or shoulder pain. You don't just put a cortisone injection in, you think about
like, sweet, we're done.
Surgery should really be coming after all of those treatments. So historically we've had a role of pain forever, then see the GP, then lost in the weeds for years, and then eventually gynecologist surgery, and that's been sort of the linear approach to endometriosis, and that's absolutely incorrect. Absolutely incorrect. Like, if that's been a woman's experience, then she needs lots more help.
I guess
only seeing a gynecologist or only seeing a gynecologist.
I guess we've kind of touched on this a little bit already, but like, why is it that women so often put up with pain for so long before seeking help?
That's complex and that's layered. I think there's a role of, that's our lot as well. We suffer, and pain is part of our lot, and kind of misunderstanding and lack of education amongst medical professionals of the role that pain can have in a woman's life and what the sources could be, and research into women's health and women being part of clinical trials and access to specialist support has been difficult and is still difficult in lots of areas. So and women just been told that's normal. So women feeling like it's normal, but then being told it's normal. Okay, it's normal. And it ends there. So So
and sorry to interrupt you.
No, carry on.
So some pain also, I think that's also important to think about with endos. Not everyone does have endo, and it's not something to be scared of. Like, periods can be painful, particularly when they start, and there is evidence that they can be painful initially and sometimes improve if you have children later in life. We don't know why that is, but it's a muscle. There's lots of prostaglandins when you menstruate. We know, but doesn't mean that you have to put up with it. It doesn't mean it's necessarily endo. And so I think that can then get morphed into pain's normal. Well, you adjust to it, and there's strategies around it. And honestly, I think in the past people didn't really know what to do with it. And let's not get on, Niamh and I on a soapbox, or all of us on a soapbox too early today. But really, the evidence is evolving
Yeah.
because we haven't studied it.
And
we don't know.
what
And
would you-
that's just women's health in general.
Yeah.
Correct.
What would you say to women that, oh, like, they're watching this, they're listening to this, they're like, this is me. I'm feeling dismissed in the healthcare space. Like, what can women do to stand up and advocate for themselves if they feel like, you know, they're not really getting what they need out of healthcare?
Be as prepared as possible.
Yeah.
So go online, research practitioners,
Yeah.
and find a practice or find a practitioner that you feel like will listen to you, is skilled and will listen to you.
Yeah.
And then be as prepared as possible. Go into that appointment with a list of symptoms, things you're worried, write it down, things you're worried about, things you've been told in the past, things you've tried in the past,
Yeah.
what's worked, what hasn't worked.
Yeah.
As much information as you can have about yourself,
Yeah.
your concerns, and what you would hope from that appointment with that practitioner at
Yeah.
that time. Because as a practitioner, I can listen to a person and examine a person, and I, at the end of it, may have a diagnosis and a list of treatment which might be completely at odds with what the person has come to me for. Now, not
Yeah.
always,
Yeah.
but sometimes I'll focus on a real medical thing, and then the person will be like, no, Eve, I just want to know why I'm having painful sex, and I just want you to fix that
Yeah.
because that's ruining my life. And I'm like, oh, okay. So
Yeah.
just be as prepared as possible coming into an appointment and know what you hope from that appointment.
Yeah.
Because if a woman knows what she's hoping for, and I say hoping because none of us have magic wands,
Yeah.
but if she knows what she's hoping for, then hopefully she'll leave with some sense of they listen to me and they're going to help me,
Yeah.
even if we don't sort it out in one go.
I have patients that if you feel like you can't find a GP, an adequate GP in your area, there's definitely patients that go to see the women's physio.
Yeah.
And those women's physios are often incredibly experienced, and they will advocate for a practitioner.
Yeah.
Or sometimes say go back, like help write a letter to the GP, you then get a referral to a gynaecologist. And there's nothing wrong with saying to your GP, can I please have a referral to a gynaecologist? I mean, that's in your right to do that. And in some ways it should be helping the GP because you're asking, a specialist to be a member of the team. I sometimes think maybe there's specialists out there that want certain things done before they get referred to. Most gynecologists that work in this space actually want the referral earlier.
Yeah.
So if you go to the GP and say, I'd like to see a gynae, I think be open to everything though when you're going to go for an opinion with someone about all the things they're going to talk about.
Yeah.
And then also realize that often you've had pain for some time, it will take a few visits. So kind of, a journey of and think about what your goals are. So when I get a referral from a GP, I look at it, but I ask the patient, when you were coming today, what were you hoping was going to be addressed? Because it's really important that that's an opportunity to say there. And so even with your GP saying, I want someone to, this is an issue to me, I really would like some advice or help around it. If you feel dismissed, just be like, please can I have a referral? And I just think if that's not provided for you, that would be I would see a bit more of a minority. But then you could also, I would say, self-refer to your physio or get a care plan to go to the physio, which you can initiate now without a specialist.
Yeah.
And start that process.
Great.
That's what I'd recommend. Don't worry about advocating for yourself. And the guidelines state that that's what should be happening. So the Living with Endometriosis guideline is very good, and also the Pelvic Pain Foundation are two fantastic guidelines. Exactly. Where you get your kind of advocacy from.
We've been talking a lot about period pain, but we don't often talk about endometriosis and what it can mean for intimacy. Can you share some of the impacts?
Yeah, definitely. I'd be also really keen to hear when Niamh sees it as it from a GP point of view too, because by the time I think patients come to me, it's around pain and this real fear and they're so worried about having sex. It's so painful.
Yeah.
Stress on the relationship, sometimes partner not feeling good or great, and the partner's worried. So and there's this kind of, it's a bit of almost a terror about it. And so there's a lot of times that normalizing it, explaining why. I think I talked about my hitting the hot stove response, and this is a normal, your body's protecting you, but work with it. And so working with like-minded physios and explaining what they'll do and I guess the why behind what's happening now. And then there's often then the pressure around possibly if they're trying to fall pregnant at the same time.
Yeah.
This double thing, it's really hard to have sex. And, fertility in itself can put a lot of pressure on a relationship. So I guess giving reassurance that this is really common and that we have really good strategies that will help with this, but it takes time and it's committing to a process.
Yeah.
And that it's not going to be a fixed thing, but an improvement. And, but we've got to kind of walk the journey together for a while. And really, it's a great example of when someone comes in, I'm like, what's the single most important? If you could pick 2 things when you saw me today that you thought, gosh, I hope Edwina can help me with this.
Yep.
They say that one or something else. I'm like, okay, let's focus on that. And then this is what, let's get you here's some great physios in the area. This is what they do. I try to kind of signpost what the physios will do.
Yeah.
And then, we can improve this.
Yeah.
But we've got to kind of walk the journey together.
And that's got to be so empowering for the patient to sort of, sometimes you go to an appointment and you think, right, I'm going to be fixed in an hour as everything's going to be sorted because you get your hopes up.
Yeah.
But to have practitioners who are really good at kind of explaining that, this is going to take a while, but we're all kind of in it together to give the patient a bit of, give the power back to them a little bit and not feel like they're just so out of control, but they're paying over the situation.
Yeah, I feel like a diagnosis off the bat can feel really overwhelming for someone. I know when, the women I'm friends with be like, oh, I have endometriosis, and it feels like this big, scary word. What is often the first conversation you have with someone after they've received a diagnosis? What do they usually say?
That's a really good question. And it very much depends on the woman's journey so far.
Yeah.
So if it's a young woman, late teens, early 20s, she's been suspecting it, and if it's confirmed, that can be a little bit of relief, but also her worst nightmare come true. Because sometimes there's a belief that means that she won't be able to have children, or it's going to be very hard to have kids, or life in general is going to be a bit miserable. So it can be quite upsetting. For women who have had decades of suspected endometriosis, it can be it can be a relief, but also there can be a lot of anger there because she spent so much of her life in pain and dismissed and invalidated. And particularly if she's had fertility struggles, particularly if she's had relationship struggles, particularly if she's had horrible experiences with medical professionals. And so that's why we involve pain psychologists and psychologists a lot as standard practice in endometriosis care, because it can have a huge impact in a person's life and a person's mental health, and how the person reacts to it is a very individual thing. Very individual. And the conversation when they're diagnosed is very much led by them and what they need now. So and that can be totally different for 2 different women.
As Niamh kind of touched on, she was kind of talking about fertility. How does endometriosis impact fertility, and what would you want women to know about that conversation?
Yeah, it's a great question. Can I add just to what Niamh had said before about the diagnosis of it? I feel that receiving a diagnosis of endometriosis, I think, similar to what Niamh said, can be several things can happen. There's like almost a relief, like a validation. There's and then there's a total fear, like, oh gosh, what does this mean? And I think it's important to not be scared of it. It's diagnosis like anything, having diabetes or being told that you've got dysgraphia, you've got some, asthma. It's a thing. And then we have really effective stuff around it. Plus, it impacts on everyone differently. Certainly with women, and then there's women that actually were actually quite really upset and sad that their symptomology is not explained by endo. And they're the group of women that it's like, we're not going to abandon you here.
That's, sorry to jump in, but often I see women more upset that they weren't given a diagnosis of endometriosis, because now they feel like they have nothing. And all the people that said it was normal are right. And they're living with this horrible pain.
And I don't have endo.
What about me? What is it?
So the diagnosis of not being endometriosis sometimes can be absolutely devastating.
But I say, but that's okay. We just know where we're going to target. You've got pelvic pain.
Exactly.
No endo. You've got pelvic pain. And
that's really important.
We're not going to, because in the past I think it was no endo, bang, up you go. Whereas now it's like, no, you have pelvic pain. It's not endo, but it's this, and we need to now really target our treatment here. And some of the stuff is still the same, but we're going to now look at some of the bowel causes or gut therapy, or that's why the physio that maybe they hadn't seen before is really important now.
Yeah.
And so it's just that whole circle of people. And so framing that, but again, I have that conversation before the surgery, and that's why when people are wanting, well, when we're thinking about surgery, I'm like, it's what's the role of the surgery, and if it's not endo, we're really going to have to do these other things. But when they do have endo, they're the patients that I often to say it possibly is. I confirm it with their histopathology. I show it to them in the diagnosis with pictures, and then I try to see them quite quickly post-operatively, because there is a lot of, what about my fertility? What's it going to mean? So fertility is its probable own session on the couch together, I think. But the single biggest predictor for fertility is age. And we know that 1 in 10 women have endo. Probably when you think about patients coming with infertility, it's maybe 30% of them. But not everyone that has endo will have infertility. Not everyone that has endo actually has pain. So there's a group of women we find out only about their endo when they can't fall pregnant. So what I say to people is, when they've got, so say they've seen me through the symptom pain pathway, and this diagnosis has led to that, I then talk about, okay, well, what we now want to do is preserve your fertility, like don't smoke, don't get chlamydia and gonorrhea, like think about your age and understand it, and the and then possibly the hormonal suppression. When people say you must do this because of endo progression, we actually don't know. So we know that endo will either stay the same when it's excised. There was a French study where they actually kept on looking every year, and it's not a great study, but it's one of the only ones we have that shows that if you have endometriosis and you do nothing, 30% will regress, 30% will stay the same, and 30% will advance.
So it's really interesting.
But I find that once they know they have endo, sometimes that's okay, well, now I will have, okay, I'll maybe get the right hormone for me to suppress it, because their hormones are now, that like they kind of understand the role of them. And then with their fertility, I say, when you want to have a bub, if you can't and your cycles are normal, come back in 6 months. Like, remember the endo's in there, but it might not be a problem. And the amount of patients I've had that have been terrified about having a baby, and I've actually had really bad endo and then haven't had a problem. It's not just been, like it's not kind of A equals B equals C. If it was, it'd be really easy. But it's just reassuring. We know about it. Let's just manage what the symptoms are at the time. And then again, when you're ready to have a bub, consider this endo, but your age is the most important thing. So if you're 38, 39, you had endo at 25, 26, it was bad, and then you were going to then wait till you're like maybe later to have babies. It's going to be hard anyway to have a baby at 38, 39. We'd possibly talk about fertility preservation. But does it mean you're going to not be able to have a bub?
What's the actual mechanism for the infertilities? Are we talking because like a physical obstruction, like the tissue, like what's...
Can we find it out together and we're going to Nobel Prize? But postulated to be different things. So the inflammation. And then the adeno component of endo, like the big globular uterus. We know that that's there's so much estrogen around, so probably anti-precisionogenic, so the implantation might not work. And then there's possibly endo can impact on numbers of eggs, the way ovaries move and things like that. But so you want to kind of keep it quiet to preserve fertility, but it's not a threat. You have to. It's a understanding. And then most, if it was really advanced endometriosis, again, that's something that we maybe surgically treat it, try to keep it quiet, and then say, about this, still give it a go getting pregnant, but we'd move that group of patients quickly to kind of assisted reproduction if needed. And then think about them if they were, I kind of said, just come back and see me around 30 if you haven't had a bub, and we'll think about egg freezing if you needed to, but also it's not the fertility stuff, it's something to consider, but age and other things impact on fertility, and you've got that in your control.
I would love to know too, what are the implications of endometriosis if it is left untreated?
Yes, so I don't have the kind of answer for you on that, because I don't think we really know. It depends on the stage of it, and it depends on the symptoms. So if someone's got no symptoms, it's not impacting on their quality of life, and they have quite significant endo, and we see that and we think, I don't know how you didn't. Doesn't matter.
Yeah.
It's all about what are their symptoms.
Yeah.
And then what are they trying to do with fertility?
Yeah.
Yeah.
All right. Courtney, many people don't realize physiotherapy can play a role in endometriosis management. How does it help?
Thanks, Lara. Yeah, I'm quite passionate and proud that physio has a big role in being able to help people with endo and pelvic pain. So, as pelvic physiotherapists or pelvic health physios, we for someone coming to see me, the typical treatment, I guess, would involve, to start with, lots of education, listening to the person, what's bringing them there. As Ed and Niamh have already sort of mentioned quite a bit, trying to understand what that woman, girl is expecting from the treatment, what they're wanting to get out of it.
Yeah.
Like, what's their main issue, what's their main concern. The education involves talking just about pain, the nervous system, the muscles. I'll ask all the questions, like questions about sex, questions about pooing, questions about weeing, so bladder, bowels. Yep, all the questions. I'll often teach people like how to sit on the toilet, ways to make pooing easier. The more, I guess, tools that I can give that person to be able to manage and help control their pain, and if they're having a flare and stuff like that. Also teach people lots of just like techniques. So breathing's an important thing. So a lot of the time when you're in pain, change the way you breathe. You'll sort of split and not breathe properly, and then that influences the pain in the central nervous system as well. So I'll spend a bit of time teaching people how to breathe properly. Stretches, there's lots of really good, beneficial, nice stretches that can help pain in the pelvis. And then there's the internal component. So when we're talking about the pelvic floor and the muscles, so when there's pain, and Ed talked about before with intercourse and sex, often anticipating pain, it makes you tighten up and tense up. So it's just learning about that and what those muscles are doing, and trying to teach those muscles and the nervous system that it's okay. So we're trying to, what we call down train. So we're trying to calm it all down. But yeah, there's a component of that where, like, a lot of people know that if you've got a trigger point in a muscle, to get in and to release it, it'll let go, it'll come down. So we do some internal pelvic floor muscle work. We'll get in and stretch and just gently work on the actual muscles in the pelvic floor.
And Niamh, why is managing endometriosis more than just treating the pain?
Because it's a really, really debilitating condition. It's a chronic condition, which means that a person will have it for their whole menstrual life. So it's a condition that starts at the onset of periods, and usually the symptoms, if the woman has symptoms, end around menopause. So for the whole of her menstrual life, if she has endometriosis and she's symptomatic with it, that's decades. And if she's having, painful sex, or going to the toilet's difficult, or fertility issues, then that absolutely needs to be treated. And pain is one part of it, and it's a big component for a lot of women, but it's the validation, it's the explanation, it's the education, it's living with that condition, that model of care that we employ for everything. It's a diabetes, asthma, it's living with the condition, and endometriosis needs to be addressed exactly the same in a multidisciplinary team. Pain psychologist, GP, physiotherapist, dietitian. There's a huge overlap between irritable bowel syndrome and endometriosis. So nutrition, working with gut health, all of the above.
And what gives women the best chance of improving their quality of life when it comes to endometriosis?
I think quality of life, I think in a lot of particularly chronic health conditions, it's all about feeling like you're in control. And so even though there might not be an easy answer or a quick answer, there might not ever be, you might not ever be cured of whether it's your endo or whatever chronic condition. But what I find is when women feel that they're in control, then their ability to cope is much greater. And that's what we want for these women, and for women we see at the clinic all the time, is, you know, the idea that they're in charge.
Yeah.
You know, you're the boss here, like
Yeah.
not the doctor, not your friends who've got all these opinions. Like,
Yeah.
and so you can just see it in women when they just feel like they're on a journey to try and sort this out.
Yeah.
But you can just sense it then when they're in control, and it's, I've got a plan of how often I see the doctor. I've got a plan with the physio.
Yeah.
I've got a plan with the psychologist, and you can just see that even if the pelvic pain isn't resolved, I think just having some control and not just feeling like they're floating in the wind and
Everything's happening to
everything's
them.
happening to them. I
Yeah.
think as soon as you get that bit of control back and have a bit of a plan,
Yeah.
you can sense that people get a bit of quality of life back
Yeah.
straight away, even just from that. And that's where, having that team and getting everything in place and then setting off on the journey,
Yeah.
you can see that kind of have a pretty quick impact.
And if a woman is listening today and she's recognizing herself in this conversation, is going, oh, that's me, what's the first thing you would want her to know?
That there's lots of healthcare professionals who are highly skilled in this, and there's lots of healthcare professionals who want women to live their best lives and to reach out and make contact. And the second thing would be, if she finds that she's not getting answers, she's not feeling heard, to get a second opinion. But the third thing that I would say is to not be afraid of prescribed hormones.
Yep.
They get a bad press, and I think it's a legacy of doctors not explaining what these treatments have done in the past, but they're a treatment for endometriosis.
And you're talking about for Hill?
Yeah, I am. Yeah, birth control pills. They do get a bit of a bad, not exclusively birth control pills, but sure, they're a big part of it. Don't be afraid of them.
Yeah.
Don't be afraid of them, and don't let the internet cloud your judgment. And even if you've had previous experience with prescribed hormones and the pill that you didn't love, there's an awful lot of different preparations. So if one didn't suit you in the past, let's have a chat. There could be one that's better this time around. So don't be afraid of them.
Thank you for listening to this episode of Women Out Loud. For more content, check us out on socials at Women Out Loud or Surf Coast Women's Health Group. Leave a comment or a question for the girls, and we'll see you next time.